We're talking about diabetes separately from other endocrine disorders just because so many of our patient population is affected by diabetes. So the learning objectives, the type 1 and type 2, pathophysiology and treatment, signs and symptoms, complications, relevant to PT practice. What is our role in managing patients with diabetes and recognizing when to alert the supervising PT, as per usual. So diabetes is extremely prevalent. More than 100 million Americans have diabetes or prediabetes. It's nuts, right? So, type 2 diabetes is increasingly common worldwide. So, it's not just in the US, it's worldwide. It is, when you look at this chart, there's a chart in the book where they break it down by gender and ethnicity. It's really interesting. But this one just blows my mind. One of the things to think about, though, is the populations in those areas. There just aren't, there's some areas of the Western United States that just aren't really heavily populated. So you're not going to have a lot of um, diabetes diagnosed in those unpopulated areas. But it is staggering. So it is diabetes is a major health concern affecting multiple body systems. So really there are, besides type 1 and type 2 diabetes mellitus, there is another type of diabetes that's called diabetes insipidus. And so diabetes was originally identified and named in the olden days, like in Roman times. And the symptom that got people's attention the most is people peed a lot, call it polyuria. There's some other symptoms that we'll talk about too, but they didn't have a lot in the way of lab tests in Roman times. And so one of the things they used to do is they used to taste things. So diabetes mellitus means sweet. So when they tasted the person's urine, it tasted sweet. Okay, luckily we don't have to do that anymore because we have lab tests. Diabetes insipidus is a deficiency of antidiuretic hormone, and when they tasted the person's urine, it tasted not sweet. So insipidus is what the thing is. So the only common symptom between diabetes mellitus and diabetes insipidus is the polyuria. So we'll talk about it. So in the normal process, when things are working as they should, the pancreas produces insulin and insulin helps the glucose enter cells. So I always say insulin escorts the glucose into the cells. Blood glucose levels decrease because it's going into the cells, and the pancreas releases glucagon when you need more glucose to mobilize glycogen from the liver and convert it into glucose. Our brain cells need glucose. They cannot use any other form of fuel. Our other body cells can use proteins and fats and break them down and turn them into carbohydrates, but our brain cells need glucose, period. So we need to have glucose available and we need a way to get it into the cells. When you have diabetes, something's wrong with your insulin production. Either insulin is not being produced, and that's type 1 diabetes, or the usage is impaired, and it can be insulin resistance where there are fewer receptors. The insulin is there, but it can't get the blood sugar into the cells. So if you can't get the blood sugar into the cells, then you have hyperglycemia. You have too much glucose in your blood. And it affects multiple body systems over time. So type 1 versus type 2. Type 1 diabetes is also known as insulin-dependent diabetes or juvenile diabetes because it's often diagnosed when someone is young, usually diagnosed in childhood or young adults, teenagers. It requires insulin injections because the autoimmune destruction of those pancreatic beta cells means your body has the inability to make insulin. There have been in Australia, they have done successful pancreas transplants, and that's considered a cure for type 1 diabetes, which that's pretty cool. 5 to 10% of all diabetes cases are type 1. So a pretty small percentage. And that's rapid onset of symptoms. Type 2 diabetes is decreased insulin production, even though your body still makes insulin, and insulin resistant. So maybe there aren't as many receptors on the cells. Your body's not as responsive to insulin. It's usually diagnosed in adults, older adults particularly. Type 2 diabetes initially may be managed with diet, exercise, and oral medications. 90 to 95% of all diabetes cases are type 2. It's a gradual onset and it may be asymptomatic in the early stages. So the signs and symptoms, whether you have type 1 or type 2, the classic three Ps, they call it, polyuria, polydipsia, and polyphagia. So polyuria, you pee a lot. Polydipsia, you're thirsty a lot. And polyphagia, you're hungry a lot. So that is usually how they tell in teenagers when they're diagnosed when they have type 1 diabetes is like, yeah, what's the deal? They're so, and when you look at body types, type 1 diabetes, they're like thin and hungry. And type 2 diabetes, they're thick and maybe not hungry. I don't know if they're hungry. Um, but the reason that we'll talk about the reasons for all the different things, but for the reason that you're excessively hungry is because the nutrients are not getting into your cells. So additional signs of diabetes, especially type 1 early on, unexplained weight loss, fatigue and weakness, blurred vision, slow healing wounds, and frequent infections. So this is some of the symptoms cross over and some of them don't. With type 2 diabetes, usually weight loss is not a thing, it's the other way around. But slow healing wounds, frequent infections, those, and fatigue and weakness. So we need to watch for acute complications, and I'm going to talk a little more in a little more detail about the acute complications. So one of them is extreme hypoglycemia, which is also known as insulin shock, which can cause confusion, sweating, and shakiness. Um, Diabetic ketoacidosis is the opposite. It's hyperglycemia, and the symptoms that you can assess are a fruity smell to the breath or an acetone smell like nail polish remover, dehydration, and an altered mental status. Chronic complications include neuropathy, which is numbness and tingling and pain, especially in the feet, core wound healing. So people with diabetes are more susceptible to pressure sores and cuts, and neuropathic ulcers. Cardiovascular disease, there's an increased risk of heart disease and stroke, and vision problems because of diabetic retinopathy that affects the optic nerve. So insulin shock or hypoglycemia is more commonly happens with type 1 diabetes. It's not as common with type 2 diabetes. It's so when you're doing if you have type 2 diabetes and you are on insulin replacement, then this is a possibility. It can occur because of excess oral hypoglycemic drugs, which is usually the early treatment for type 2 diabetes. So you have excess insulin in your circulation and a glucose deficit in the blood. Remember, the brain needs a constant supply of glucose. If you don't have enough glucose, it's gonna really affect your brain to the point where it can be life-threatening or cause brain damage if untreated. So insulin shock often follows strenuous exercise, maybe a dosage error. They accidentally gave themselves too much insulin. Vomiting, because you get rid of all your whatever glucose was in your stomach. Skipping a meal after taking insulin. And I have a good story, which I've recorded, and I'll send you a link to it so you can know what this looks like. So, so the signs that you'll see are disorientation and a change in behavior, and the person may appear impaired, and you don't know why. It could cause anxiety or decreased responsiveness, either one of those two, and a decreasing level of consciousness to the point where people can lose consciousness. Decreased blood glucose level, decreased blood pressure, and increased heart rate. Immediate administration of glucose is required to prevent brain damage. So insulin shock is a very serious acute complication of diabetes. The other side of it is diabetic ketoacidosis, which is hyperglycemia, extreme hyperglycemia. It occurs in insulin-dependent clients and it's most commonly seen in type 1 diabetes. So it's a result of insufficient insulin in the blood, high blood glucose levels, and mobilization and use of lipids to meet cellular needs that result in the production of keto acids. So it's often initiated by infection or stress. So it could also result from an error in dosage, infection, which I already said, a change in diet, alcohol intake, or exercise. So if somebody has an unusually large meal, like it's Thanksgiving, and they go to somebody's house and have an unusually large meal, that could set off diabetic ketoacidosis. So the signs and symptoms of diabetic ketoacidosis are thirst, dry, rough oral mucosa, and warm, dry skin. So the person in insulin shock has pale, moist skin, and the person in diabetic ketoacidosis has warm, dry skin and that acetone breath. So that's the thing. If somebody's unconscious and you look and they have a diabetic alert tag, that's how you're going to tell whether it's one or the other. So rapid deep respiration and acetone breath, lethargy, and decreased responsiveness. Metabolic acidosis is what's causing the symptoms, and it may lead to loss of consciousness. Electrolyte imbalances, abdominal cramps, nausea, vomiting, lethargy, and weakness. When people have diabetic ketoacidosis, they admit them to the hospital and they try to get their electrolytes balanced and try to get their acid-base balance corrected. So very serious, life-threatening, acute complications of diabetes. In order to diagnose diabetes, it's based on the presence of any one of four factors. One of them is the clinical symptoms: polyuria, polydipsia, weight loss, blurred vision, random plasma glucose, regardless of last meal. So normally, if you don't have diabetes, you eat a meal, your blood glucose goes up because you just took in food. The insulin goes up to meet it. It escorts the glucose into the cell. The cells use it, and life goes on. Um, if you're fasting plasma glucose, if you have random high glucose without eating, well, then that's a sign. If your fasting plasma glucose is greater than 126 milligrams per deciliter, um, you have to be fasting for at least 8 hours and your glucose is still high. That's an indicator. They do a glucose tolerance test where you load glucose, and if you 2 hour post the glucose load, your glucose level is still greater than 200 milligrams per deciliter, then that is indicative of diabetes. And sort of the gold standard for diabetes diagnosis is A1C. If it's greater than or equal to 6.5%, then you are considered to have diabetes. If it's between 5.7 and 6.4%, you're considered to have prediabetes. And if it's below 5.7, it's considered normal. So A1C is a measure of how much your blood sugar has fluctuated in the last few weeks or so. And so that is why that is considered a standardized test and a marker for chronic glycemia and glycemic management. So we want to maintain blood glucose levels in a normal range to help reduce complications. Diet and exercise, of course. Exercise reduces blood glucose level because skeletal muscle uses glucose. And exercise can take the place of insulin for escorting glucose into those skeletal muscle cells, which is lovely. Common diabetes medications include insulin, various types and timing. Some of them are long-lasting, some of them are fast-acting. Metformin is the most common oral medication, and sulfonylureas are a common oral medication that can sometimes cause hypoglycemia. Oral medications increase insulin secretion and reduce blood glucose levels. So that's for type 2 diabetes because you can't increase insulin secretion with type 1 diabetes because you don't have the proper cells to do that. So you need to replace insulin. So exercise recommendation for type 1 diabetes, regardless of the type of diabetes, the American Diabetic Association recommends regular physical activities for overall health and wellness. So with type 1, it's really important to balance insulin doses with food intake and activity, even when performing ADLs. So people with type 1 diabetes should be encouraged to plan ahead and know their body's typical glucose response to exercise so they can keep their blood glucose from going too low or too high. And well-managed diabetes, you can avoid complications if you really work on managing your diabetes. For type 2, the American Diabetes Association recommends both aerobic and strength training. Aerobic exercise helps the body use insulin better, and then all the other good stuff that aerobic exercise does. So the ADA recommends 30 minutes of moderate to vigorous intensity aerobic exercise at least 5 days a week, or a total of 150 minutes per week. And that's for the rest of us too. Strength training or resistance training makes the body more sensitive to insulin, so it decreases your insulin resistance and can lower blood glucose and helps to maintain strength and reduce the risk for osteoporosis and all that stuff. So some type of strength training at least 2 times per week in addition to aerobic activity. So exercise is good. We want to do it. We know that, right? So our key responsibilities in diabetes management, we're going to monitor blood glucose before, during, and after exercise. Most people, almost everybody that I've worked with type 1 diabetes in recent years has an insulin pump and they monitor regularly. People with type 2 diabetes, a lot of times they monitor regularly too. And so patients will tell you, and you can even say, hey, next time you come in, can you tell me what your blood glucose was right before the session? That sort of thing. You should be able to recognize the signs of hyper or hypoglycemia. Make sure that there are snacks available during the treatment if people need it. Inspecting feet daily, we can educate our patients to inspect their feet daily for wounds or pressure areas. If they can't do it themselves, some people just can't see their own feet. You can teach them how to use a mirror or teach their family or caregivers to inspect their feet daily. Monitoring vital signs and exercise response and communicating changes as necessary. Never ignore dizziness, confusion, or unusual fatigue in patients with diabetes. That could be a clue that something serious is going on. So, patients with diabetes present with a wide range of individual normal values. So, part of in the initial evaluation, the PT might be talking with the person about what their exercise tolerance is and what their kind of normal range of values is. Now, I talked with one person with type 1 diabetes who said when they were doing a cognitive task, like say taking an exam, something like that, they wanted their blood sugar to be a little higher because their brain needed it, brain needed the glucose. When they were doing a physical task, they wanted their blood sugar to be a little lower. So most people with type 1 diabetes have had years and years of trying to monitor their blood sugar level, and they kind of know what their tolerance is. So be sure to verify their blood glucose level before you start physical therapy. A pre-exercise glucose level less than 100 milligrams per deciliter, you might need to give them a snack before starting the activity. Modification of exercise parameters are going to depend on what else is going on with them. So if somebody's had surgery or an orthopedic injury or something like that, they're going to be under more stress and it's going to be harder for them to manage their blood glucose levels. So you want to monitor blood glucose before, during, and after exercise and have quick acting carbs available. You actually can have delayed hypoglycemia up to 24 hours after exercise. And if someone injects insulin into a limb that you are then exercising with, it can cause increased insulin uptake, possibly causing insulin shock. So that's something to be aware of for sure. A lot of PT clinics have a diabetic emergency response kit. The insulin is necessary to maintain proper lipolysis and glucose production during exercise. So performing exercises without adequate insulin can lead to hyperglycemia and ketogenesis, and that could lead to diabetic ketoacidosis. So coordinating PT sessions and home exercise sessions with meals and insulin injections may help optimize exercise tolerance. So Keeping glucose sources like graham crackers or honey or glucose tablets in a diabetic emergency kit can be helpful in case someone is hypoglycemic with activity. We're always going to document blood glucose readings if the patient checks or if you're in an inpatient setting and the nurse checks. That is something that we're not going to check. We're going to do vitals, of course, before, during, and after treatment. We're going to monitor the patient's energy level and exercise tolerance, and we're going to document that. We're going to document any skin changes, wounds, or areas of concern. We're going to document any patient reports of dizziness, fatigue, or pain, and any medication compliance issue that the patient reports. So communication is really important. And when in doubt, you're going to ask the supervising PT what they need to know about the patient. So patient education opportunities abound when you're working with people with diabetes. We can reinforce the importance of regular monitoring. We can reinforce the importance of proper foot care and daily inspection. We can reinforce the benefits of regular exercise for glucose control. We can recognize the signs of hypoglycemia and the importance of medication compliance. We can let the patient know when to seek medical attention. So PTAs provide education within the scope of their practice, and they reinforce the PT's teaching. So I'm not going to tell people to change their dosage on medications because that's outside the scope of my practice, but I am going to provide education within the scope of my practice. So red flags: sudden confusion, dizziness, or altered mental status. That's a big red flag. Severe hyper or hypotension, signs of hypoglycemia, so shakiness, sweating, confusion, chest pain or severe shortness of breath, high fever with a rapid heart rate, new or worsening wounds, especially on the feet, and or if the patient reports missing their medications. Document everything and communicate promptly. So the American Diabetes Association guidelines are really nice to check. There's the Endocrine Society Clinical Practice Guidelines, and there's some good review questions in Chapter 13. If you can get a diabetes education certificate as a PTA, that's something you can do for professional development and stay current with evidence-based practice and attend continuing education on endocrine disorders. Remember, lifelong learning is essential in healthcare.